Hello, my name is Chrissy Wilhelm, and today I'll be presenting on otitis media, one of the most common childhood infections worldwide. We'll cover its causes, disease process, epidemiology, treatment, and prevention using evidence-based recommendations. These objectives guide our session today. We will be defining acute otitis media and otitis media with effusion, describing pathogens, pathogenesis, and biofilms, and we will summarize diagnosis management, epidemiology, risk factors, and prevention. OM can be acute with symptoms or an effusion without an infection. Reoccurrence is a major issue in pediatrics. Otitis media is an inflammation of the middle ear that can present in different forms. Acute otitis media involves a rapid onset of symptoms such as ear pain, fever, and other signs of infection. Otitis medius with effusion occurs when fluid accumulates in the middle ear without the presence of acute infection, often following an episode of AOM or due to eustachian tube dysfunction. Recurrent otitis media is diagnosed when a person experiences 3 or more episodes within 6 months, or at least 4 episodes in 1 year, often indicating an underlying susceptibility or persistent risk factor. This image showed you the difference between a normal eardrum and a bulging tympanic membrane. 3 bacteria dominate OM cases, though viral URIs often precede bacterial superinfection. Otitis media is commonly caused by both bacteria and viruses, with bacterial pathogens being the most frequent culprits. Streptococcus pneumonia, a gram-positive coccus, is one of the leading bacterial causes, often producing more severe symptoms. Haemophilus influenza, a gram-negative coccobacillus, and Moraxella catarrhalis, a gram-negative diplococcus, are also frequent offenders, particularly in recurrent or persistent cases. Viral agents such as respiratory syncytial virus, RSV, rhinovirus, or influenza virus can either directly cause otitis medius or predispose individuals to bacterial infection by damaging respiratory tract mucosa and impairing the eustachian tube function. This diagram shows how URI-related swelling can block the eustachian tube, leading to fluid stasis and bacterial proliferation. Eustachian tube dysfunction, often triggered by swelling from an upper respiratory infection, can lead to a negative pressure in the middle ear. This pressure imbalance allows fluid to accumulate behind the eardrum, creating an ideal environment for bacterial or viral growth. As pathogens multiply, the body's immune system responds with inflammation, causing pain, redness, and swelling. In essence, impaired drainage sets the stage for infection, turning a simple blockage into a symptomatic case of otitis media. This shows why some of the OM cases don't resolve despite antibiotics. Biofilms act like a shield. Haemophilus influenza often form biofilms on the mucosal surface of the middle ear, creating a protective matrix that shields the bacteria from both antibiotics and the host immune defense. This biofilm structure makes it difficult to completely eradicate the infection, allowing bacteria to persist in a dormant state and later reactivate. As a result, biofilms play a significant role in the development of recurrent or chronic otitis media, contributing to prolonged symptoms and frequent relapses. distribution is not uniform. Socioeconomic and geographical disparities matter. Otitis media is the leading reason for antibiotic prescriptions in children, with the highest incident occurring between 6 months and 24 months of age, when the eustachian tube is still developing and immunity is immature. The condition disproportionately affects indigenous and rural populations, where factors such as limited healthcare access, higher rates of respiratory infections, and environmental exposures increase risk. Globally, the burden is substantial, with the estimated 709 million cases each year, highlighting both the widespread nature of the disease and the impact of the socioeconomic and geographic disparities on its prevalence. There are risk factors that can be modifiable and some are non-modifiable. Risk factors explain why prevention must include both medical and lifestyle strategies. Non-modifiable would be age, sex, and family history. Modifiable ones could be choosing of daycare, making sure that there's no smoke exposure, and breastfeeding. Vaccination has reshaped the bacterial landscape of OM, shifting the predominant pathogen. The introduction of the pneumococcal conjugate vaccines has significantly reduced cases of otitis media caused by Streptococcus pneumonia. However, this shift in bacterial ecology has been accompanied by a relative increase in Haemophilus influenzae as a causative agent, reflecting changes in pathogen dominance following targeted vaccination. In addition to bacterial vaccines, the influenza vaccine plays an important role in prevention by reducing viral infections that can trigger secondary bacterial otitis media, further emphasizing vaccination as a key strategy in managing the disease's incidence and pathogen profile. Diagnosis should be based on otoscopic findings, not just symptoms. Acute otitis media, or OAM, is diagnosed based on 3 key criteria: a sudden onset of symptoms, the pressure of the middle ear effusion, and signs of inflammation such as a bulging or erythematous tympanic membrane. Accurate diagnosis relies on careful otoscopic examination rather than solely on reported symptoms, as visual confirmation of effusion and inflammation is essential to differentiate AOM from other conditions like otitis media with effusion or external ear infections. This approach ensures appropriate management and treatment decisions. There are several different treatments that can take place. There could be watchful waiting in select mild or unilateral cases. They can use over-the-counter for all to help manage the pain. And there's amoxicillin as a first-line antibiotic that can be used when indicated. For recurrent OM and OME, there is tympanostomy tubes. Most people just refer to them as tubes that can be placed in the ear. The tube is inserted into the eardrum to allow the drainage of fluid. This usually happens when kids are younger than 3 months or under 4 years. Older than 3 months and in 6 months or 4 years. Another procedure that can be considered is adenoidectomy, which is where they go in and they take out the adenoids, which are usually enlarged and blocks the eustachian tube and the air passageway. When the eustachian tube opening is blocked, that can prevent fluid from draining and air to flow. Prevention and counseling. Parental counseling is vital. Prevention starts at home. Breastfeeding in children that are less than 6 months increases their maturity in development. You can avoid smoke exposure and get your child vaccinated for PCV and influenza. Another thing that can help is hand hygiene, making sure you're doing a good job of washing hands and surfaces, and the daycare infection control. If you would like more information on any of these topics, here's a list of references. Thank you for listening.